Good morning, everybody. Great honor to have the Barrow Neurological Institute and its phenomenal faculty and fellows here today with a very challenging topic, and that is tumors in the spinal column and neural axis at the top and bottom, frequently affected by delayed recognition and certainly challenging clinical decision-making and execution. Nobody better to take us into this than Drs. Uribe and Turner. Juan, good morning.
Good morning. Dr. Chapman, it's a pleasure for us to be here and have Dr. Jay Turner with us. I will just let Jay Turner to get started and lead the session today. Dr. Turner, thank you for joining us today.
Great, well, thank you. Thanks, Dr. Chapman. Thanks to the Seattle Science Foundation for the invitation. We're going to presenting kind of a hybrid format for the journal club, presenting a couple of papers, but also focusing primarily on surgical technique and presenting a couple of cases as well. So we'll have a little bit of literature, but also some case discussion. We treat as neurosurgeons, orthopedic surgeons, we treat quite a bit of tumors. Tumors that show up at the top and bottom, present unique challenges, both in diagnosis and management with unique anatomy, which is fascinating as surgeons. And we're going to focus on those two regions today, and we're going to start with a discussion of sacral tumors and specifically nerve sheath tumors. So we have first Dr. Clint Morgan, who's going to be presenting a paper. Clint is a PGY 6 and enfolded spine fellow at the Barrow Neurological Institute. It's going to take us through the first paper. Dr. Morgan.
Thank you. Getting screen sharing going here. Can you see the slides there?
Yes, looks good.
Okay. So as Dr. Turner mentioned, I'm Clint Morgan. I'm the sixth year residence in neurosurgery at the Barrow, as well as Dr. Uribe's enfolded spine fellow. So I'm going to talk about a paper that came out in 2019 in World Neurosurgery. This paper is out of a Japanese group discussing basically a small case series of about 11 patients in which they discuss piecemeal subtotal excision versus piecemeal total excision versus partial resection of these giant sacral schwannomas. So they present a case series and a literature review, and I'm going to discuss that here. So as we all know, schwannomas in the spine are relatively rare, but more commonly we see them in the thoracic spine, less commonly in the cervical and lumbar, and then far less commonly in the spine. So about 1 to 5% total incidence of these schwannomas appearing in the spine occur in the sacrum. Even less common, giant sacral schwannomas. These really inflict their damage by, even though they're benign, but by being.
We have an audio problem. Can you not move or make sure that your microphone is connected well?
Sure. I can come closer. Just an integrated phone. See if that's any better.
No.
Okay.
You're very muted, very remote.
And when we
it's
a buzzing.
So if you'd like, I can. We can.
Okay, here you go. Now you're good. I don't know. You can't move your head around. I think there's something loose somewhere.
It's an integrated audio, but I'll go straight in here like this. There we go. So, really, it's unclear if total excision merits the risk to adjacent neurovascular structures. And there's a lot of discussion in this paper specifically about the value of leaving a capsule, especially since that capsule is often integrated or tightly affiliated with the adjacent neurovascular structures. So they asked this question: what happens if you remove these giant sacral schwannomas, piecemeal, total, or subtotal excision, sometimes leaving that capsule with the goal of preserving function, and how do those patients do in the long term? So in the study, they took 11 patients with what they call giant sacral schwannomas. They define giant as the longitudinal length being greater than 5 centimeters. As you can see, with the time in how long it took to accumulate 11 patients, basically 19 years, 11 patients over 19 years. So roughly even split of gender between 5 male and 6 females, mean age of about 53 is which is what we would expect. The mean follow-up range of about 12 to 84 months. The mean was about 50 months. So of these 11 cases, follow-up is what they call completed, meaning that they followed these patients out for 5 years in 8 of the 11 patients, and they had no evidence of recurrence. In the other 3 cases, due to concern for recurrence or need for continued surveillance, 3 cases were still undergoing follow-up. And they define, as I mentioned before, what they called piecemeal total or piecemeal subtotal excision. Piecemeal subtotal was greater than 90% removed, where they found that total removal was going to be impossible. And this is also sometimes when they leave part of the capsule intact, specifically to preserve neurovascular function. Partial resection in this case was less than 90% removed, and this becomes important in how they define the results. So this is table 1 from this WNS paper. This goes through each of the 11 cases. You can see some of those common complaints as you'd expect. Typically, pain, leg pain, paresthesias, and numbness in the buttocks and legs.
Audio's choppy again. Sorry.
Yeah, we cannot hear you, Clint. It's really bad.
Okay. I could pause and we can have Gabby start, and I could put on a separate microphone if you'd like to do that.
That might be necessary. We literally lose over 50% of your audio for some reason. Sorry.
Yeah, let's go over. Why don't we present better? Who's the first neck case, Jay?
Well, maybe I think it's good to have the paper before the case, and maybe why don't we move over to the upper cervical? Maybe we can have Domenico move into the upper cervical paper, and then Clint, maybe we can get you to dial in with your phone just so we have more consistent audio.
That's a great plan. Yeah, so we apologize for the technical issues, but it will worth the wait because the cases are amazing today.
Okay, so this is Dr. Joseph DiDomenico. He's one of our PGY4s at the Barrow Neurological Institute, and we'll be discussing upper cervical spinal tumor management, and we'll present a paper. Dr. DiDomenico.
All right, good morning, everyone. So this is a review of an article that's basing on the management of cervical vertebral column tumors. So working up to the neck and no financial relationships to disclose. This was a paper by Dr. Shuba's group and his co-authors that was really a focus on developing a decision-making algorithm for treatment of these lesions at the occipito-cervical junction, within the subaxial cervical spine, and at the cervicothoracic junction, and the limitations that exist for each of those locations. So for these conditions, a significant amount of planning is required to account for neurovascular structures, for instability that may be introduced in the setting of these lesions, as well as the anatomic bony constraints that exist at the top and the bottom of these locations, things such as the mandible, as well as the mediastinal contents. For metastatic lesions, those anatomic restrictions are less impactful, just given the oncologic goal in treatment of those conditions. But for primary lesions that are more likely to require an oncologic resection, the anatomic restrictions become much more important, and that can vary based on the cranial and caudal boundaries for those conditions. This is figure 1 from the article. That was a nice demonstration of how this group is looking at the approach for these lesions based on where they're occurring. For those lesions that are cranially directed, lesions that may be reaching to the C2, C3 disc space, maybe localized to the clivus. So if a lesion's localized to the clivus, this group would see the appropriate approach being something like an endoscopic endonasal. Transoral approaches can reach to those locations. But then when you're looking at lesions that are coming down and extending inferiorly, that's where you're looking at the planes that they've identified as important for helping with your treatment algorithm. So the plane of the axis, the plane of the atlas, as well as the inferior plane of the mandible come into play in determining whether or not to utilize an approach such as a transmandibular approach, where a transcervical approach alone is going to be limited in your view, but an approach through the nose or through the mouth is not going to be entirely effective either. Going down towards the subaxial cervical spine and the cervicothoracic junction is where we look at the angles of the thoracic inlet, so the angle of attack that comes from that plane, as well as the plane of the sternal angle. So for tumors that localize above the thoracic inlet, but below the atlantal ring, those are those lesions that are classically and effectively treated just through a transcervical approach. For lesions that localize caudal to the cervical plexus and don't have an extension to involve a transcervical approach, those are those that are most effectively treated just posteriorly via spondylectomy. And then for lesions that bridge that cervicothoracic junction, where you see extension above the thoracic inlet, but also below, those are the ones that are going to involve a more invasive exposure given restrictions with the mediastinal contents, and are most effectively treated utilizing either a partial or full sternotomy. So this group reported on their single series of treatment for these cervical lesions. They had 115 patients treated with a mean age of 57. 2/3 of those lesions were metastatic and 1/3 were primary, which of those 1/3, 50% of their pathologies were chordoma. From an approach perspective, 60% were treated via a single stage, which the majority were done by a posterior only approach, which makes sense given the fact that the majority of these lesions were metastatic in nature. 40% were treated by a multi-stage approach, with the anterior stage almost entirely transcervical. They had 3 cases reported on that involved the transmandibular approach, where the lesion involved either the C2-3 disc space, the C2 or C3 vertebral bodies, and they measured the height above that mandibular angle that I showed in that last figure, which averaged about 3.7 centimeters above that mandibular angle, and led to an inability to get to the lesion effectively by just a submandibular approach. And then 2 lesions were described with treatment via a transsternal approach. And of note, for all of the cases where the treatment went beyond a transcervical approach, these were for lesions that were primary in nature, given the fact that the morbidity associated with those approaches in the setting of a metastatic lesion is a morbidity that's not necessary and is not part of that oncologic goal for those conditions. Overall, the complication rate, including minor and major complications, was 37%. Wound complications were approximately 10%, but the wound complications were, although there was a significantly different rate of wound complications between transcervical approaches and those that were done with those more invasive options, such as a transmandibular or transsternal approach, there were significantly less patients within those cohorts that were done via a more invasive approach. But the idea to have in mind with particularly the transmandibular approach, retropharyngeal, transoral, is the introduction of the oropharyngeal contents and the need to be concerned about those contents that may be introduced into the epidural space. Through their case series and describing the way that they approach these lesions, they developed an algorithm that they utilized to think about these lesions, starting with metastatic lesions. For those that are metastatic, it's simpler in nature and in thought process. It's a matter of whether or not there's anterior column collapse If no, then the decision is, does the patient need surgical intervention? If there is epidural disease with cord compression, that of course introduces that need, and treating by a posterior fixation is the best way to go about it if there is greater than or equal to 3 levels involved. And if not, then evaluating whether an anterior approach is more appropriate. If there is anterior column collapse, then it becomes a matter of where the lesion is extending to. For those lesions that extend at the superior pole of the tumor below the mandibular angle, and the inferior pole being above the thoracic inlet, those lesions, given the anterior column collapse, are best treated with a front-back approach, including a corpectomy and posterior instrumentation. And for those that have a superior pole above the mandibular angle or an inferior pole below the thoracic inlet, so looking at that cervical thoracic junction, as well as those lesions that go above the limitation superiorly, that's where posterior fixation alone becomes the most effective approach. For primary tumors, things get a little bit more, not complicated, but more necessary to consider in planning, given the oncologic goal for a complete resection. So for those lesions that are localized to the clivus, an endoscopic endonasal approach is certainly effective. If not, and that superior pole of the tumor comes below the mandible, then a transcervical approach can be considered, unless that tumor is really confined below the plane of the atlas. And if that's the case, then those lesions may involve a transoral approach plus posterior fixation. If you can, with extension of the neck, see that the inferior pole is below the C2-3 disc space, then considering posterior anterior approaches combined with a transmandibular approach become utilized. When the superior pole of the tumor is below the T2 to T3 disc space, then a posterior only approach is utilized, as was mentioned in that prior image, given the fact that you can work without those restrictions anteriorly. But if the inferior border of the tumor is below the plane of the thoracic inlet, and the inferior border is below the plane of the sternal angle, then a transcervical approach can be utilized. And it's a matter of whether or not you need a partial or full sternotomy. Full sternotomy is, of course, involving more experience necessary from a cardiothoracic surgeon, as well as some further complications and limitations with the neurovascular structures. Ultimately, their algorithm breaks it down with 3 guiding principles in mind: whether there's a need for an en bloc resection, whether there's a need for anterior column access, and consideration that the tumor resection may result in further destabilization. For metastatic lesions, en bloc resection offers little benefit in the way of overall survival, and introduces significant morbidity. So as such, it isn't really the ultimate goal for those particular lesions. And in that case, a transcervical approach for subaxial lesions spanning 1 to 2 levels is certainly an effective measure. And then for multi-level involvement with 3 or greater levels, a posterior only approach is effective. Stage procedures come into play when those metastatic lesions are resulting in deformity by something such as a pathologic fracture or underlying instability. And for primary lesions, these are the ones that are going to be mostly dictated by the localization of the lesion and those restrictive constraints that we discussed, superiorly involving the mandible as well as inferiorly involving the mediastinal contents. When there's isolation to the posterior elements, of course, a posterior only approach is effective and sufficient. But when there's anterior column involvement, that's where an anterior transcervical approach can become utilized, but also with adaptations for the additional exposure that may be necessary based on the superior and inferior poles of the tumor. So we'll get into a case presentation.
Great. That was a great summary, Joe. Thanks. So yeah, these extended anterior approaches are certainly fascinating, however, very morbid. And And so typically, we use these very selectively, only when, really, full exposure of margins is necessary, as Dr. DiDomenico pointed out. Any questions or comments from other panelists, Dr. Chapman?
Jay, yeah. So I really appreciate that article. Nice summary there, Joe. Very helpful. Now, for me, the big question is always in these very complex lesions with complex locations, biopsying can be very challenging. So you actually get a representative, meaningful tissue sample, which frequently may be in the margins of the lesion and in a very precarious zone. So how do we actually arrive at a meaningful diagnosis if it's not done by phenotypical morphology on neuroimaging? So that's what I missed in that article by Dan and his team, because the execution, that's very nice and helpful, but how do we know what we're actually dealing with? Thanks.
Yeah, I think that's a great point. And, the other issue with biopsying of these primary spinal tumors is how to deal with the biopsy tract and with contamination for these tumors that have high rates of recurrence. Yeah, I think that's a great point. If there aren't any other comments, I think we'll pass the mic to Dr. Harrison Farber, PGY5 at Barrow, and who's going to be presenting a case of an upper cervical tumor.
Good morning. Does that look coming across?
Yep, looks good.
Great. Well, thank you again for having us. My name's Harrison Farber, and I'll be talking about kind of following up on Joe's talk, a case of a C2 chordoma that was treated here. So the patient was a 48-year-old male, otherwise healthy. He presented mainly with neck pain, some mild myelopathic symptoms. He actually had been, once he came to us, had already undergone a biopsy. He had undergone an open transoral biopsy of his lesion that you'll see momentarily, and the pathology had come back as chordoma, and then he was referred over for definitive treatment. Here's the patient's imaging. You see as an enhancing lesion involving the C2 body with some ventral extension. Here's the CT scan, which shows it as a pathologic fracture, it's a lytic lesion. And then lastly, here's the CTA, showing that the vertebral arteries are relatively spared by this particular lesion. So this was patient, otherwise healthy. We did have tissue diagnosis of a C2 chordoma. We saw there was ventral soft tissue extension. It appeared to be relatively contained by the posterior longitudinal ligament posteriorly. There's a pathologic type 2 odontoid fracture. The patient had already undergone an open transoral biopsy, which meant he had a contaminated biopsy tract. Patient had codominant vertebral arteries. The left was slightly larger, but they did not appear involved. So I'm coming up with a plan for this patient. A two-stage approach was determined. So first was a posterior approach with a laminectomy for decompression, as well as a posterior fixation with a posterior release of the C2 body, as well as a vascularized occipital bone graft on a semispinalis pedicle supplied by the deep cervical artery. Stage 2 was then a transoral approach, including a mandibular split. Plan was to achieve margins where able and achieve a wide excision of the prior biopsy tract. And then for the patient to undergo an anterior reconstruction from the clivus to C3 using a Harms cage. And also a radial forearm free flap for closure of his oropharynx. So we'll play a video here. This is from stage 1. This is the posterior approach. So the patient's head is to the left here. At this point in the case, the laminectomy has already been performed. So this suture is retracting the C2 nerve root, which has already been sacrificed. And significant work has already been done to get down to the ventral aspect of the body. Here, the vertebral artery is being unroofed. and access to the C1, C2 joints is being obtained. And you see we're actually excising into the C1-2 joint here to help release. Here in the video, it's actually been flipped. So the head is now to the right side, and the occipital bone graft has actually been taken from the patient's left side and laid down. And again, the graft was plated from the skull to C3. So after stage 1 was completed, stage 2 was then performed. Here's the approach with the planned incision on the left and then with the actual opening on the right. This exposure was done with the help of ENT and plastic surgery colleagues. Here's a video from stage 2. So after exposure, here's the prior biopsy tract. So this is the excision of the mucosa with wide margins. The C1 anterior arch is then encountered, which will be removed. Again, the patient's head is to the left here. So now we're looking at the tip of the dens. Here, the ligamentous attachments, including the apical ligament, is being removed to help release the ventral aspect of the dens. Again, working around releasing the ligamentous attachments. Here, an osteotomy cut is being made into the C3 vertebral body to help define the distal border. Because of the pathologic fracture, it could not be delivered as one block. So that was the tip of the dens that was just removed. And then here's the rest of the tumor being removed. There were some small pieces adherent to the PLL and to the dura, so these nodules are all then resected. After complete resection was performed, then they turned to anterior reconstruction. This was a custom pre-cut Harms cage that was placed, and fixation was achieved from the clivus to C3. And again, a radial forearm free flap was used following the stage to fill in the mucosal defect. Here's a picture of that Harms cage, the pre-cut cage. And then here is some immediate post-op imaging showing the construct to obtain a little sturdier fixation. Pedicle screws were placed as the distal fixation anchor at C4 in the subaxial spine. Here again is some immediate post-op imaging showing this construct. So the patient did undergo a PEG tube placement on post-op day 5. He was advanced to a PO diet. Once he was cleared by our ENT colleagues, they wanted him to wait until 3 weeks post-op. When he was discharged from the hospital, he was on trach collar and went to acute rehab. At the time of his first follow-up visit, the trach had been removed. He went on to receive adjuvant proton beam. Here's the patient at 1 year post-op. This was talking to Dr. Turner on telemed due to COVID. You can see he was doing really well, and you can see the nice recovery that he had. Here's 2 year post-op imaging, MRI on the left, obviously with instrumentation artifact, but really no evidence of local recurrence. And then here's the 2 year post-op CT scan showing anterior and posterior evidence of fusion.
Great. Well, thank you, Harrison. Can open it up for discussion. You know, I think there's several different challenges with these types of tumors. The first relates to diagnosis, as Dr. Chapman pointed out. Second is the surgical treatment. But then, another important aspect for these is long-term durability of your construct and actually achieving fusion in a very non-hospitable environment where you have a radiated tumor bed. And so, these surgeries, when going for really a aggressive approach, can be very morbid, but give the best chance for be more aggressive, gives the best chance for potentially a surgical cure and better long-term durability.
Jay, question in the chat room, vertebral artery involvement. If you have a case where one side is heavily encased and you want to try to get as radical as possible, just quickly walk us through how you kind of go through that.
Yeah, no, that's a really important point. And, in this case, it was fortunate that there was really, we had, break through the cortex ventrally and posteriorly, but the lateral margins were favorable where there was good, good normal bone laterally. So we're able to just release the vertebral arteries without having to do much with them. In the case of vertebral artery involvement and trying to get margins, yes, if you're often vertebral artery sacrifice is necessary, and being able to do it safely is key. So ensuring that a patient can tolerate sacrifice before doing that. Getting a en bloc with a brainstem stroke is obviously not a good outcome. So ensuring they can tolerate that sacrifice.
So trial balloon occlusion prior to surgery, and then sacrifice as long as you have an intact posterior circulation. Is that the strategy?
Exactly. Yeah, exactly.
One more question, the choice of cage. So with the possibility that you have to have adjuvant radiation, a titanium cage can kind of deflect a lot of stuff. And I've kind of been told by many of my radiation colleagues that they prefer a biologic construct like an allograft over titanium. What are your thoughts in terms of that? And does it matter to proton beams as much as to conventional stereotactic, whatever radiation?
Yeah, no, it's an important topic, and we have actually great non-metallic options for other areas. So, doing thoracolumbar tumors, for example, we have a lot of good, carbon fiber PEEK options. In this location, having a graft and something that has the right mechanics and the right size and shape is a little bit more challenging in this location, spanning the clivus down to C3. And so we discussed all those options. We searched for non-metallic options, which just weren't available for this location. But certainly, radiation oncology colleagues prefer non-metallic implants, which wasn't a good option here. And structural allograft certainly an option. Structural autograft could also be an option that could be fashioned in that area. My concern there is in the setting of radiation, if you have osteolysis of that graft, you end up with a huge defect without any structural support ventrally, and having some sort of non-biologic option there to provide anterior support was the thought process here. All right, if there are any other comments, we'll move back to Dr. Morgan. Hopefully we have those audio issues sorted out, and we'll transition back over to sacral tumors.
Let's try that again. Is that any better?
Much better.
Yes.
Okay. And I'll briefly review what we had already talked about so we don't miss anything, and then I'll get started again here. So just to review what we had discussed before. So this is a paper from 2019 from World Neurosurgery, Japanese group, with a case series of 11 patients, specifically discussing outcomes related to giant sacral schwannoma. So they present a case series and a literature review. Yeah, there we go. So as the group knows, most common location for schwannomas are heavily predominant in the thoracic spine, followed by the cervical and lumbar spine. Far less commonly, we see these schwannomas in the sacral spine. So about 1 to 5% overall of schwannomas that we see in the spine occur in the sacrum. Giant sacral schwannomas, they are benign often, but are, basically inflict their damage by being locally invasive, by pressing on things and compromising neurovascular structures. And it's unclear, even now, if total excision is necessary, if it merits the risk to adjacent neurovascular structures, which can often be adjacent to or integrated with the capsule itself, surrounding the benign schwannoma. So they asked the question in this paper, what happens if you remove these giant sacral schwannomas, piecemeal, total, or with a subtotal excision versus partial excision, and how do these patients do in the long term? So this is a rare pathology. So over the span of about 19 years, they were able to report on 11 patients, about five males, 6 females with a mean age of 53. Pretty significant follow-up, so a range of 12 to 84 months. The mean follow-up was about 50 months. So most patients had relatively long follow-up. And follow-up was what they called completed in 8 of 11 cases because there was no evidence of recurrence occurring out to 5 years. But the remaining 3 of the 11 cases still were undergoing follow-up. And they defined what they called piecemeal total versus subtotal excision as basically the idea of knowing that total removal was likely impossible in the case of piecemeal total excision, but or subtotal excision. But if they left the capsule on the tumor to preserve the neurovascular structures adjacent, do these patients still do well? And they also had this separate group called partial excision, which was less than 90% removed for those tumors. So this is the overall summary of patients that they reported on. And so as we know, most of these patients with sacral tumors tend to have, buttock or leg pain or paresthesias. A couple of patients, however, one patient had dyschezia and polyuria. And you can see the duration fairly wide in terms of symptom from the duration of time of symptom onset. 6 patients overall underwent angiograms preoperatively. Of those 6, 5 actually had embolization and 1 did not. And they also divide up into 3 different groups, these sacral schwannomas, what they call intraosseous type. Second would be dumbbell type. And the third type would be retroperitoneal type. And for the retroperitoneal type, they classically treated these with the anterior-only approach, with the intraosseous type, a posterior-only approach, and with the dumbbell type, a combined anterior and posterior approach. They also report operative time and blood loss and complications and overall outcomes. This is an example from the paper in which they describe a giant sacral tumor from the S3 nerve root. You can see sagittal views and axial views on the right. And they also show an angiogram showing the tumor blush that was involved in this case, which was ultimately embolized from the inferior gluteal artery. This is a gross picture anatomically from the OR showing the left S3 nerve root. You can see the nerve root edges there kind of on the with the arrows there. And this is what they call piecemeal total excision. So you can see a little bit of a capsule there near the root. And this is what they call piecemeal total excision. And you can see a nice decompression of that area in this case. So overall, of these 11 patients, 7 of 11 patients presented with buttock or leg pain or paresthesias. 3 out of 11 patients just common to this area reported bowel bladder symptoms as their primary presenting complaint. And that was sometimes a neurogenic cause, and that was sometimes more of an obstructive cause due to just the mass of the tumor itself. Wide range of symptom onset, so 2 to 276 months with a mean of 132 months from the time the patients first noticed symptoms to the time that they ultimately presented. And as I mentioned before, they sort of divided up between these 3 types, which were defined as retroperitoneal, dumbbell, and interosseous. One of the 6 patients who underwent angiogram preoperatively ultimately could not be embolized, even though it was a giant sacral schwannoma due to bilateral internal iliac feeders, which were not amenable to embolization. Average operative time was 434 minutes. One patient had postoperative motor weakness, which they say improved after 2 years. One patient had some causalgia, underwent a pain management caudal block. One patient intraoperatively had an internal iliac injury and resulted in significant hemorrhage, I believe about 13 liters. All cases, they say, had symptomatic improvement after surgery. And importantly, really, which was the kind of goal of the small case study, of those patients with partial excision, which if you recall, they defined as excision of less than 90% of the tumor. 2 out of 3 of these patients experienced regrowth during the follow-up period. One of these 2 patients required repeat surgery at 7 years, and this was one case of those. However, of those cases of piecemeal total or piecemeal subtotal excision, which were 8 patients total, none showed recurrence. And again, they define that as leaving part of the capsule to preserve function. So just in the discussion section, they kind of go into how they divided up these patients in the retroperitoneal, intraosseous, and dumbbell types, and the approaches that they took consistently on these across these 11 patients. They make the point of this is, even though this is a small subset, the previous case series describing these patients of giant cervical schwannomas typically had a follow-up of 5.2 years. Here was about 11 years. This is the overall summary of their sort of literature review of all the different papers that have been published on this topic. Just a nice kind of follow-up in their discussion section. And that's all I have. Thank you very much for your time.
Excellent. Thanks, Clint. So yeah, yes, sacral tumors, certainly unique anatomy, and a lot of the tumors we're dealing with in the sacrum are often require those aggressive resections with margins. Nerve sheath tumors most of the time are benign, and neurologic preservation can also often be achieved, and so less of aggressive approaches can be considered without having to get margins. And so I think it's a rare entity, and there's actually very little published literature on the topic of giant nerve sheath tumors. And so I think that was a nice summary, Clint, and open up for any discussion.
Yeah, quick question also from the chat room. Charanjit want to know nerve root preservation, especially unilateral, bilateral, S3, S4 continents, and any intraoperative tips on how to identify intact neural elements to separate them from tumor disease. So thank you.
Juan, do you want to comment?
Yeah, I can add that. The classic teaching is that if you're able to achieve a unilateral preservation, specifically of the lower sacral nerves, there could be a good chance to preserve sphincters, which it makes a big difference on lifestyle, as we know the patients. It's amazing how much morbidity give you sphincters dysfunctions. So that one, every time we treat specifically schwannomas, we do our best to isolate the root where the tumor is coming from. Unfortunately, in some cases, the size of the tumor can be distracted to the surgeon, and you end up sacrificing nerves that at the end, when the tumor is out, you figure it out that was not enough. So that's why we like to first start working on the pseudocapsule of the tumor. So you incise the tumor a little bit, find a pseudocapsule, and then you start finding your way that, and doing a really good intratumoral resection. That way you can collapse the capsule later on, and that's the opportunity to save some of the other nerves. And this is also to answer some of the chat questions that was coming on. I don't know, Jay, you want to add something? I know that you have a really good experience with sacral schwannomas.
Yeah, no, I think that summarizes it well. Yeah, I think a lot has to do with what compartments are involved. Is it outside the sacrum? Is it destructive to the bony anatomy? How many nerve roots are involved? But certainly having good neuromonitoring and with sphincter monitoring, especially for the lower sacral nerve roots, is important for trying to preserve as much neurologic function as possible. But I think back to the diagnosis, really what you're dealing with, the most important feature for how you're going to approach it surgically. The benign tumors, especially schwannomas, are typically very slow growing. And so I think, in those situations, neurologic preservation is absolutely key. So getting that accurate diagnosis first, I think is really important.
Yeah. And And the other thing, Jay, I'm going to ask for the audience, because I know this question happens a lot on this type of tumors. And the question is, when do you instrument or not on sacral tumors, Jay? You can answer that question ahead, because I'm sure it's going to come, and I would like to make sure that we cover this important part.
Yeah, no, that's a really important part of this. So yeah, it really comes down to the mechanics and how much of the SI joint you need to sacrifice, and unilaterally or bilaterally. There's various clinical series and biomechanics studies looking at this, of when you definitely need to instrument versus when you should instrument. Certainly, if you're taking the sacrectomy up to the S1-2 level, that requires reconstruction in most circumstances. Actually, I would say essentially all circumstances. Partial sacrectomies, S3 and down do not, and and in between, requires some, I think, individualized decision making. But the sacrum is a posterior ring of your pelvic ring, and can get into devastating issues if you do have postoperative mechanical failure with the sacrum. So that's typically how I think about it. Is anything above S2, 100%. Anything below S3, rarely, especially if it's bilateral involvement, and in between, individualized. How about you, Juan?
Okay, so Dr. Paisan, Gabriela Paisan is one of our superstar residents at the Barrow. She will illustrate one of our group sacral tumors treated on the last few years in our institution. So Gabriela, you can present the case, and we can keep with the discussion the last 10 minutes of this session.
Can you all see my notes, or are you seeing my slides?
All good. Thank you.
Okay, sounds good. So as Dr. Uribe said, I'm Dr. Paisan. I'm PGY4 at Barrow, and I'll be presenting a case of a sacral peripheral nerve sheath tumor. So our patient was a 25-year-old otherwise healthy female presenting with progressive back pain and pain that radiated down into her lower extremities. She denied any paresthesias, and her back pain had started to interfere with her sleep. She also had an unintentional weight loss of 40 pounds. No other relevant medical or oncologic history for her, and neurologically, she was completely intact with normal bowel and bladder function. On her MRI, you can see that there is a 9 by 6 by 8 centimeter heterogeneously enhancing sacrococcygeal soft tissue mass with T2 intrinsic hyperintensity. The mass extends into the left sacroiliac joint without fully crossing the joint, and is encasing the left S1 through S4 nerve roots. It butts the right-sided sacral foramina without completely encasing them. The mass extends anteriorly and inferiorly from the sacrum and displaces the thecal sac. And the fat plane between the sacrum and the rectum is maintained. On her CT, you can see that the mass is also eroded through surrounding osseous structures. So differential for this patient includes nerve-shaped tumor, schwannoma, neurofibroma, primary sacral bony tumors, chordoma, which would be most common in this location, germ cell tumor, and then metastasis. First, a biopsy was performed. CT needle-guided biopsy showed a most likely schwannoma with epithelioid features. The decision was then made to take her to the OR for stage resection. This procedure required a multidisciplinary approach with assistance from plastics, colorectal surgery, OBGYN, and vascular surgery. Preoperatively, she also had IR embolization of the tumor via internal iliac feeders. Surgery was managed in 2 stages. The patient first underwent an anterior approach through L5-S1 discectomy, and sacral osteotomies were completed with a bone scalpel and anterior partial sacrectomy. The S1 through S5 nerve roots were identified and resected. Subtotal anterior resection of the tumor with ultrasonic aspirators, curettes, pituitaries was performed. Surgical teams from other disciplines were essential to complete this, as this also required a total abdominal hysterectomy, bilateral salpingectomy, and laparotomy for rectal mobilization and the creation and elevation of our right rectus abdominis flap. The flap was then left on the presacral area on the bed of the tumor at the end of the anterior portion of the case. This is our postoperative imaging from stage 1 with a partial sacrectomy and partial tumor resection. The posterior approach was completed the following day. Paraspinal muscle flaps were elevated to the lumbar portion of the lower spine wound with a preserved vascular pedicle to eliminate dead space in the wound. The biopsy tract was excised and the tumor was resected, preserving the right-sided distal sacral nerve roots. Neurectomy of S2, S4, and S5 nerve roots on the left was required. The tumor was resected with a combination of curettes, suction, and ultrasonic aspirator. Navigated instrumentation from L4 to ilium with rod connectors replaced to reconstruct the pelvis. Here are our intraoperative images of the hardware in place. You can see good placement of the hardware and a multi-rod construct. Our immediate postoperative imaging is shown here, showing complete resection of the tumor and reconstruction of the pelvis with no residual tumor. And here's our CT as well. Postoperatively, the patient remained intubated for 1 day. She ultimately was extubated and required 6 days in the ICU for monitoring. She did require a suprapubic catheter placement prior to discharge due to urinary retention, and on discharge was ambulatory with a walker. And you can see her wound here in clinic, which had started to heal nicely. Postoperatively, at her 8-month follow-up, she was completely neurologically intact. Her suprapubic catheter had been removed, had no bowel or bladder issues, and she had minimal back and leg pain. Her incision was also well healed. You can see her here with Dr. Uribe and one of our previous residents, one of Dr. Uribe's previous fellows, Dr. Corey Walker, who's now attending at Cedars-Sinai in LA. Right, here her post-op standing scoliosis films showing good alignment, and her 22-month post-op MRI is shown on the right. On the left is her preoperative imaging showing no recurrence, no residual. That's all.
Great, thanks, Gabby.
Okay, Jay, you want to do all the Jerry Springer, the closing statement? So we move, and we appreciate the entire SSF for this huge effort to educate the world on the spine, and also obviously our big mentors from Texas Back Institute, Dr. Geyer, and the whole crew for this. You're mute, Jay.
Oh yeah, absolutely. No, I certainly appreciate the opportunity, and it's an honor to be. It's just SSF has taken over the online spine world and is providing such enormous educational content. It's really, truly an honor to be able to participate. So thank you for having us.
Hey, Jay, thank you. And thank you for the kind words, but it's all the multiple contributors and quality colleagues around this growing network that make it happen. So thanks to you guys. Hey, a question about that lumbopelvic case. So I think this raises a couple of questions. One of them, Gabriela, so beautiful images, by the way. I really liked your juxtaposition of these images. That's, I think, how we should all present those cases. So I'm going to put your slides down as this is how it should be presented. So we have it all together. Very nicely done. So how was the fusion done of the lumbopelvic junction? Having done a lot of sacrectomies in my life, that's always something I was challenged by. So this looked very beautifully done. But what was the actual bonding of the lumbopelvic junction consisting of?
Oh, you're on mute, Juan.
Yeah, sorry, I will take the answer so we don't put Dr. Paisan on the burning flames of the question. Yeah, so Dr. Chapman, totally agree with you. The Achilles tendon of these lumbosacral pelvic lesions is actually achieving a long-term fusion. And as we knew on the demographics on the Dr. Morgan paper, most of these cases actually belong to young patients, and because of the nature of the pathology, the patients will not die from this. So the game is decrease morbidity and achieve a good fusion. In our case, we've been moving through the years. Now what we're using lately is obviously make sure that we have a really good fixation first as the mothership of a good stability foundation. So we like to put at least 4 iliac screws, and then we start at least from L5. So we get L5s and then go all the way to L4 in cases that the whole sacrum and we don't have porches of NS1. And then the connection between the two sacral SPSIs or the sacral ala, you name it. Usually what we do is we put a titanium mesh, similar to the one that we use on the cranial plasties, and we make it like a canoe, and we attach it with a classic titanium Songer or Sonntag cables, and then we put a lot of BMP and BBM on there. But however, as you know, crossing that gap is almost impossible. But that's our best strategy. We also, the other way that we decrease morbidity is very important, no matter what. It's just not that you are able to close the skin dorsally. You need to move a flap of muscle from the front so you feel the dead space, because if that dead space is still there, then we'll have a lot of complications in terms of filling that gap with fluid and seromas and this and that. I wanted to know, Dr. Chapman, if you have any strategy from your own experience. I know that you're dealing with a lot of this tumor in your career.
So so I don't have any great other options to point out. I totally agree with the 4 screws. I use 4 rod constructs nowadays, and we're working on better cross links, so having a meaningful left to right connection. I still try to use either titanium mesh and fill it with an autograft strut graft, or have historically in younger, smaller patients also used a tibial shaft or femoral shaft from left through right with a through and through SI screw. We'll have in the near future much better SI screws. And I'm not going to mention any companies, but I think that's still one of the holy grails. And again, your construct is absolutely beautiful. And of course, the result speaks for itself. The other thing, very briefly, I wanted to point out is that when we deal with these sacral tumors, we have to tell our patients that most likely they will lose bowel and bladder control. However, we try to preserve S3-4 unilaterally. The reality is that due to their loss of their sympathetic plexus, they at least for a long time have a bladder dysfunction. So I think how you handled that was very nice with a suprapubic catheter, but telling patients beforehand about the reality of this is, I think, a very big deal and helpful from our end to have them on our side and avoid surprises. Rick,
just before we leave, one quick comment. Remember, most of our patients have 12 really nice ribs. And I've harvested a couple ribs to rebuild the sacrum, which gives you a nice piece of bone that you can fashion split and put that in the area to bridge the gap.
Really good idea.
From here, do you want to take us out and close us out? But thank you, Barrow, thank you, Juan, Jay, and team. But Izzy, do you want to give us some final big picture commentary?
Sure, big picture. I'm glad that Juan is doing this now, because I really don't want to be doing this anymore. These 12, 18-hour cases are very, very challenging, and Juan, you showed a great example of it. So those watching, this is the pearl of spinal surgery, being able to tackle the cervical thoracic junction, the occipito-cervical junction, and now the lumbosacral junction for these tumors. Have a good weekend, everybody. Enjoy.
All right, thank you, Barrows. Thank you, Juan. Get your voice back.
Yeah, thank you. And just to close, I just want to make sure that for all of the audience and everybody here, we're very grateful to continue supporting SSF, and also Izzy is actually Jay Turner, our monster in terms of big cases. You know, we're getting older, and now Jay is the stallion dealing with all these things. So thanks very much.
All right,
Take
goodbye.
care. Have a good weekend.
Appreciate it. Thank you, everyone.